begin, we are going to go over some of the shoulder anatomy, just kind of a brief review here. What we call the shoulder girdle actually includes the clavicle and the scapula, kind of as a set, even though in our shoulder imaging we do include the proximal humerus, but the actual shoulder girdle only consists of clavicle and scapula. So to begin with the clavicle is kind of the easiest, the most simple. We have the sternal end, which helps to form the sternoclavicular joint. And then we also, and that end is a little bit more blunt, a little bit more straight up and down. On the lateral aspect, we have the acromial end, which would form the AC joint, the acromioclavicular joint, with the acromion of the scapula. So two ends on the clavicle. Now in the middle of that, every clavicle will be a little bit different depending on if it's a male or a female clavicle. Male clavicles tend to be a little bit more curved and thicker due to the muscle in the male patient. Female clavicles are thinner and tend to be a little bit more flat, so they don't have quite the S-shaped curve to them. As far as the clavicle goes, that's about it, just the two ends and then that middle body section. For the scapula has quite a bit more anatomy on it. We'll move to this little model over here. So we'll start out with some basic scapular anatomy. We have three borders, three angles, and two surfaces. So the three borders that we typically refer to are the medial border, which is closest to the vertebral body, so we also call that the vertebral border. We have the lateral border, which is also termed the axillary border in relation to the axilla, and then the superior border, the highest portion. For the three angles, we have the superior angle, which is a very important kind of positioning landmark, as well as the inferior angle. Those are the two most commonly used ones. And then we have the lateral angle. Looks a little bit better on this one. The lateral angle is actually kind of where the head and the neck of the scapula are. So this most lateral portion here right behind the coracoid. So superior, inferior, and lateral are the three angles that we talk about. As far as surfaces, the two surfaces, on the anterior view, we have what we call the costal surface because it associates very closely with the ribs, the costal margin. And so costal surface is this entire anterior section. Within that, we have what we call the subscapular fossa. It's kind of the indented portion, the site for muscle attachment on the anterior view. Also on the anterior view, on an AP, we would see what we call the scapular notch, a little indent between the superior border and where the coracoid projects out, so a little scapular notch. Tucked in kind of right behind the coracoid. Our second surface is the dorsal surface. Looking at the shoulder from the posterior view, dorsal surface is the whole back aspect of the scapula. We do have a few other kind of positioning landmarks that we use here. This kind of ridge is what we call the spine, and this is the crest, the thickened area that projects off of that spine is the crest, and we can typically feel that and follow it outward until it curves around and becomes the acromion. Also on this posterior, we see the supraspinous fossa and the infraspinous fossa, attachment sites for the muscles that correlate with those two areas. As far as PA projection or PA, this is what kind of the anatomy that you would be viewing there. The last view that we use is the Y view or the lateral view, shown better on this one. In the lateral view, what we see really well is the more kind of lateral aspect of the scapula. We are seeing the acromion and the coracoid and the relationship of these to each other. Notice that the acromion is a little bit flatter. It's a more superior structure, but it also sits more posterior, almost partly behind the glenoid fossa. Whereas the coracoid is very anterior. It's the most anterior structure on the scapula, and it also sits very inferior. It's about the same level as the glenoid fossa. So we can see that relationship very well in the Y view. And we also see the actual glenoid cavity or glenoid fossa that helps to create the glenohumeral joint when it associates with the head of the proximal humerus. So as far as scapula, there's quite a bit more anatomy and terms in relation to the clavicle. Lots of different projections that we can use there. Now the last one that we have to talk about is the proximal humerus, because we do include this in shoulder anatomy since it helps to make up the main shoulder joint. We do have to know the different sections of the humerus. So we'll start with the humeral head, the rounded most superior portion. It's also the most medial portion, articulates directly with the glenoid fossa of the scapula. This is the only bony attachment, the only bony articulation between the body and the upper extremity. Everything else is muscle and tendon attachments. So this is the only bony articulation, this joint. Directly below the humeral head is what we call the anatomical neck. It's kind of a line that sits at a bit of an angle, a little bit of a ridge that kind of comes through here. And so that's the anatomic neck directly below the head. It is above the tubercles. So the next thing, and very, very important, we use these a lot for positioning and for critique of images, are the greater tubercle and the lesser tubercle. The greater tubercle sits a little bit more laterally, and in an external projection, we see that in profile on the lateral aspect. The lesser tubercle sits more on the medial side, so when we do internal rotation, we can see that in profile on the medial aspect. Now, in between those two tubercles, we have a divot or a groove. It's called the bicipital groove or the intertubercular groove. And there are actual special projections that you could do to make sure that that groove is very open between those tubercles. Now, working our way down, we have a very definite line here. This is where the growth plate is, and this is going to be what we call the surgical neck. Typically in surgery, this is where they're going to do the cutting rather than at the anatomical neck. So surgical neck is below the tubercles, whereas the anatomical neck was slightly above them. And then the last piece of anatomy is a little bit lower than that. We have kind of a roughened area, an attachment site. It's called the deltoid, and that's for your deltoid muscle to attach on your deltoid tuberosity right there. Anything below that we don't include in the shoulder imaging, so we'll just kind of leave that for general anatomy. The three joints in the shoulder, glenohumeral, created by the head of the humerus and the glenoid fossa of the scapula. The AC, the acromioclavicular joint, acromial end of the clavicle, and the acromion of the scapula. And then the third joint is the sternoclavicular, the SC joint on the far end. So three joints that have to be included in your AP shoulder imaging to get a full shoulder image. The last thing is the landmarks. There are a few very important landmarks that we use for most of our shoulder imaging. The AC joint, which we can find by following the crest from the posterior aspect around. The AC joint you can feel on most every patient, as well as the superior angle. Those are going to be two of our main ones for our Y views, getting true Y views, getting true Grashis. So AC joint and your superior angle, posterior aspect, as well as your greater and your lesser tubercles. Those are very important in our AP imaging with internal and external rotation. You always have to make sure that you include the entire clavicle in at least one of your images. And so the SC joint, the sternal end of this clavicle, also kind of becomes an important landmark to feel and palpate on a patient to make sure that we do include at least that far over. Those are about the main landmarks that you'll be able to feel on pretty much all of your patients most of the time.